In this video, I'm going to discuss different causes of the conductive and the sensorineural hearing loss. Now, with the conductive hearing loss, there is problem with the passage of the sound waves through the external or the middle ear, as a consequence of which these patients are usually have problem with the perception of the low frequency sounds, versus the sensorineural hearing loss, where there is usually damage to the cochlea, cranial nerve 8, or central auditory structures, as a consequence of which patients are usually have problem with high frequency sounds. An example of high frequency sounds is like, for instance, a child's or a female's voice. Now, regarding the conductive hearing loss, cerumen impaction is one of the common causes of the conductive hearing loss. Otitis media and externa, which are infections of the middle ear and the external ear, are also other causes. Tympanic membrane perforation, which presents with pain and ear bleeding. And finally, otosclerosis, which is a common cause of conductive hearing loss in elderly patients. And this is due to the bony fusion of the stapes and the oval window. And then we have the sensorineural hearing loss, the most common cause of which in elderly patients is presbycusis. And presbycusis is due to the degeneration of the nerve fibers as well as sensory cells at the base of the cochlea. Noise-induced hearing loss is another example, which is due to the damage to the hair cells in the organ of Corti. And then there are different drugs that can cause hearing loss, examples of which include furosemide, aminoglycosides like gentamicin, as well as cisplatin. So here I've provided you with a memory aid. Furious gentleman breaks my sister's plate. So furosemide, gentamicin, which is an example of an aminoglycoside, and cisplatin. We could also add etacrinic acid, which is also a loop diuretic similar to furosemide, to the list. Other medications also include quinidine as well as aspirin. And then we can have CNS causes of the sensorineural hearing loss, including acoustic neuromas seen with the neurofibromatosis type 2, as well as the auditory nerve neuritis seen with the multiple sclerosis and syphilis. And then finally we have the Ménière's disease, and these patients are presenting with recurrent vertigos, as well as the hearing loss that is usually unilateral. So unilateral hearing loss. And then these patients also have sense of fullness in their ears. Now, the underlying cause of the Ménière's disease is from the distension of the fluid spaces that are in the cochlear and vestibular parts of the labyrinth, as a consequence of which Sol's restriction can help these patients with the vertigo. So just keep that in mind. Ménière's disease presents with recurrent vertigos and unilateral hearing loss and sense of fullness in the ear. And then the dietary restriction of the soles can help with the vertigo. Next, I would like to show you the auditory pathway. So the cochlear hair cells will send signals via cranial nerve 8 to the cochlear nucleus, and from here on the signals will go bilaterally both to the right and to the left side, go to the superior olivary nuclei, then go to the inferior colliculus, medial geniculate body in the thalamus, and then finally goes to the superior temporal gyrus. Now, lesions of the cochlear hair cells or the cochlear nucleus or the cranial nerve 8 will cause unilateral loss of hearing. And then lesions that are above this level, since there are no bilateral pathways, will cause bilateral decrease in hearing, as well as difficulty with localizing sounds. And then finally, I would like to describe the Weber and Rinne test and how to interpret those to help distinguish the sensorineural from the conductive hearing loss. So with the Weber test, you will have to place the tuning fork on the vertex of the patient's skull. And normally, vibrating sounds are traveling better through the air than through the bone. So in normal ears, since they would both hear normally, the patient will localize the sound in the middle. On the other hand, if there is a sensorineural hearing loss, let's say in the right ear in this patient, then the sounds would go to the other ear, and thus the patient will localize the sounds to the left ear. Now, on the other hand, if the patient has conductive hearing loss, at this moment now the sounds will travel better through the bone, and thus patient will localize the sound to the right ear. So just let me repeat what I just told you here. If the patient has normal hearing in both ears, would localize the sounds in the middle. If the patient has conductive hearing loss, since the sounds travel better through the bone, the patient will localize the sound in the defective ear. And if the patient has sensorineural hearing loss, then he or she would localize it to the unaffected ear. So if this was a sensorineural hearing loss, then the patient would have heard it better in this ear. Now with the Rinne test, what you will have to do is that you will place the tuning fork on the patient's mastoid to allow the bone conduction. And so when the patient can no longer hear the sound, then you will remove the tuning fork and place it in front of the patient's ear to allow now for the air conduction. So in normal patients, given that air conduction is better than bone conduction, the patient would still be able to hear it. Same for the sensorineural hearing loss. The patient would still be able to hear the tuning fork when you place it in front of their ears. With the conductive hearing loss, however, since the conduction through the bone is better than the air, when you place the tuning fork in front of the patient's ear, they won't be able to hear it. So again, let me repeat what I just told you. With the Rinne test, you will first place the tuning fork on the patient's mastoid bone until the patient can no longer hear the vibration. Then you will replace the tuning fork and place it in front of the patient's ear. With normal hearing as well as sensorineural hearing loss, the patient can still hear the tuning fork when you place it in front of their ears. However, with the conductive hearing loss, the patient would no longer be able to hear the air conduction when you replace the tuning fork from the mastoid bone over in front of the patient's ear. And the reason for that is that conduction through the bone for the conductive hearing loss is better than through the air. And that concludes our discussion of different causes of the hearing loss.